Thanks so much.
Thank you for your beautiful presentation. So we move to our next speaker. Next speaker is Professor Massimo Colombo. His current position is a director of the Liver Center at the San Raffaele Hospital, Milan, Italy. And also he is a chairperson of the EASL International Liver Foundation. So Massimo, please start your lecture.
Good morning, Mr. Chairman, ladies and gentlemen. A special thanks to Professor Moriyama for having me here discussing the hepatocellular carcinoma after eradication of hepatitis C. These are my conflict of interest. As you perfectly know, the widespread utilization of DAA to treat hepatitis C has led to the progressive accumulation of many patients who develop liver cancer during the phase of sustained virological response. And as a consequence, there has been also a proportional increase on candidates to surveillance having had an SVR to DAA. These are data generated in America, Northern America, showing us exactly the burden of SVR patient with a liver cancer and also the burden of the patients who need to undergo surveillance. This brings me to at least three questions that are of clinical importance. Understanding why the risk of hepatocellular carcinoma is increased over the years after achieving an SVR. This is the first question. And this possibly is the consequence of the specific biology of the infections, since the virus elaborates a number of proteins that can hijack the molecular pathways that control the cell cycle, resulting in averting immune destruction of the cancer cell or cells that are progressive to become cancer, resisting cell death, sustaining proliferation activity, which in turn has also to do with an impaired T cell response that is supposed to be responsible for clearing the cells that are translating into cancer. On the top of this, chronic infection with hepatitis C is also able to induce a number of epigenetic changes that are associated with increased risk of liver cell developing a cancer. And this risk apparently will last years and decades after an SVR. And this might in fact account for the number of cancers that are identified in patients without a significant liver disease, given the fact that we were used to identify patients with cirrhosis as those who are more prone than others to develop a liver cancer. As a matter of fact, the severity of liver disease matters. There are many studies that show this. The one important comes from Northern America, the Veteran Administration Hospital, where patients have been treated for many years using interferon-based regimens, but also more recently DAA-based regimens. In this reanalysis done by Dr. Ioannou, it was clearly demonstrated that both in the interferon domain and in the DAA domain, the risk of developing cancer was greater for patients with cirrhosis and in non-cirrhotic patients, with those having a FIB-4 score higher than 3.25. I like to remind you that FIB-4 assesses is a compound score that incorporates patients' age, serum levels of both transaminases and platelet counts. Well, using this score, you can identify non-cirrhotic patients who are at risk of developing liver cancer. So severity of liver disease matters. On the top of this, you have to realize that there might be other conditions that can promote carcinogenesis in patients with chronic hepatitis C who achieve an SVR. And there are a number of studies indicating that the steatosis, metabolic syndrome related, the type 2 diabetes, alcohol abuse are associated with an increased risk of developing liver cancer in patients who have achieved an SVR to DAA. And the same is true also in the domain of chronic viral hepatitis C for those infected with genotype 3. A common feature to all these patients, those with classical metabolic related liver disease and patients with HCV genotype 3 viremia, is the fact that steatosis and lipotoxicity associated with either infection or the metabolic syndrome is an important driver of liver cancer risk. And this is something that the clinician can take into account when stratifying the patients for the risk of developing cancer after achieving an SVR. In the context of the clinical monitoring, the good hepatologist should be aware that there are patients with radiologically undefined HCC in the context of a cirrhotic or a pre-cirrhotic liver that are exactly those that upon achievement of an SVR or upon exposure to DAA may develop a rapidly aggressive liver cancer. This was clearly shown in a multi-center study done in Italy, led by Dr. Sangiovanni from my group. It could demonstrate that the early onset of a clinically aggressive cancer in cirrhotics who have been treated with DAA were exactly those patients having such radiologically undefined liver nodules. And this has been related to the fact that the swift removal or inhibition or clearance of hepatitis C virus causes a perturbation or disturbs the ranges immune-related innate immunity, thus favoring the onset of very aggressive liver cancer, early onset of very aggressive liver cancer. And this is a caveat that should be taken into account, of course. On the top of this, there has been also another caveat going forward for years that patients with an HCC that has been eradicated by either surgery or radiofrequency, who were then treated because they had remained viremic, were exposed to the risk of an early clinically aggressive recurrence. This appears not to be the case, and it was demonstrated by a large multi-center studies done in America, where data were analyzed on the basis of a meta-analysis of individual studies data, and by a large multi-center study in Europe, where data were analyzed in terms of individual patient data meta-analysis. And both studies came to the same conclusion, that there was no whatsoever evidence that removal of hepatitis C virus through DAA could lead to early aggressive recurrence of the tumor. As you see here, there are data indicating that the prevalent incidence of HCC after hepatitis C virus eradication was not significantly different between treated and untreated, and responders and non-responders. And this is clearly shown by the wide ranges of the intervals of confidence intervals here. That's an important point to remind. And a very good hepatologist is in fact fully convinced that removing hepatitis C after tumor eradication will translate in a great clinical benefit to the patient, because would prevent clinical decompensation, including ascites and hemorrhage. The second question I would like to raise is how to identify ideal targets or patients for surveillance following an SVR. And in theory, you might have two distinct approaches, as recently commented by Professor Ioannou. You might rely on the degree of fibrosis that you can estimate with various approaches, for instance, liver stiffness or FIB4, and this would separate those who do not really need surveillance because they have a trivial risk of developing cancer after SVR, and those who would need more aggressive monitoring, classical surveillance every 6 months with ultrasound. You might also have another approach, this time not based solely on the fibrosis stage, but also based on a compound score system where the HCC risk is estimated with a compound algorithm. You might use a very simple scoring system like FIB4, or you might elaborate a little bit more using hepatocellular carcinoma risk calculators to finish with the deep learning models. And these possibly are more accurate in separating those who deserve to be under surveillance from those who might go without. And these are examples of how to operate. A very simplified scoring for HCC is provided by FIT4, which is user-friendly, can be done at your desk, is readily available, but of course is not as accurate as other modalities, for instance, FibroScan or shear wave elastography, which assesses stiffness, not to speak about the multivariable regression models that are more elaborated, cannot be done at your desk and require the intervention of modeling procedures, not to speak about the deep learning HCC risk prediction model, which are even more sophisticated and definitely less user-friendly. Here is an example of what many do in clinical practice, assessing liver stiffness in different periods during surveillance might identify patients who remain with elevated values of FibroScan or shear wave elastography, or you can also rely on MR elastography. And apparently in this paper, those staying with more than 20 kilopascal over a period of a couple of years after achieving SVR are definitely those at increased risk of developing HCC, and likely to be those who deserve more aggressive surveillance approaches. Another modality to intervene, sorry, this is blocked. Another modality to intervene is rather user-friendly and was elaborated by the French group, stratifying your SVR patient based on AST levels, then further substratify the cohort according to the value of ProTime, and those who have a physiological value of ProTime are exactly those who have a negligible risk of developing cancer over a period of several years, 7-8 years. So you start with AST, those with equal or less 2.5 times the upper normal value are further stratifying those with less or equal 85% of ProTime, with those more than 85%. And finally, you identify a group of individuals who are exposed to no risk of developing cancer. It looks fine, however, when these patients have been externally when this study was externally validated, it appeared the C index is extremely low, calling from inaccuracy, obviously. One important point of screening relates to cost efficacy or cost effectiveness, if you wish. It has been clearly demonstrated that given the large number of patients that are being accumulating following SVR, you need to stratify for the risk of developing cancer in order to be cost effective. No question in this recent study that cirrhotic patients and those with higher than 3.25 FIB4 are exactly those at higher risk of developing liver cancer and should represent the ideal target for screening in terms of cost efficacy. But this, of course, relates to liver disease severity. There is another important variable to screening, which is adherence and ability to be accurate with the surveillance tool. So you might have an optimal surveillance scenario where a patient has a very well compensated liver and all of them comply to screening, and here ultrasound are cost effective. However, if you fall in another scenario where surveillance is inadequate because of liver disease severity or because there is less than optimal rate of adherence, then surveillance with CT followed by MRI provide an yield that is considered to be cost effective in terms of ISR. Along this line, a study has recently been published by the group of French colleagues, where patients with multiple etiologies, but which however included also FC-cured individuals, underwent stratification based on different modality of surveillance. Surveillance according to recommendation, ultrasound every 6 months, versus surveillance that was reinforced given the fact that US were added on with fast magnetic resonance every 6 months. And the second approach led to the identification of many more patients with HCC in the very early stage BCC 0, leading to an ICER that was considered to make surveillance with this modality really cost effective. The very last question we wish to raise is what is liver scientific societies recommend in terms of screening and surveillance for patients who achieve an SVR. If we stay in the West Hemisphere, you see that the Europeans are keen to recommend screening with abdominal ultrasound every 6 months for both patients with advanced fibrosis and those with full-blown cirrhosis, whereas the Americans do not. What about the Asian world? A little bit the same. Patients at older age with biochemical signs of poor hypertension, clear-cut clinical signs of cirrhosis are in fact associated with a higher risk of developing cancer, and therefore these patients require surveillance. Surveillance is also advised for those patients in whom cirrhosis appear to be regressed either histologically or through liver stiffness assessment following an SVR. And with that, I'm finished, and I thank you very much, all of you, for the attention.
Thank you very much for your very comprehensive presentation. Any question? So in this session, discussion time is set on the 15 minutes. However, the 5 presentation is completely different. So it is difficult to discuss about the same theme. So we omitted the discussion time. Instead of the discussion time, 1 or 2 questions is accepted after each presentation. So if any question, so please raise a hand or post it in clinical Q&A column. Thank you. So any question? So I have one question for Professor Colombo. So in the era of the immunotherapy era, so I think the HCV infection is gathered in the lymphocyte in the liver. So easy to respond by the immunotherapy. So my question is, what is the differences on the responses by the immunotherapy between the HCV infected patient and HCV irradiated patient? Professor Massimo is not here.
No, yeah, I'm afraid that he is not live.
Okay, so please.